So my name's H.Parks. I'm an orthopedic surgeon, which means that I'm a mechanic. I'm a mechanic of the human body, and I work on knees and hips and shoulders. And tonight we're going to talk about knees. And the purpose of this talk is so that when you leave here, you have a better understanding about how knees work and what happens when they don't work, and some of the solutions that we have to take care of knees that don't work well. It's a pretty broad topic, and I'm going to assume that you're starting out without much basic knowledge, so I'm going to try to make it clear, not too technical. And if I wander into the technical stuff too deep, just raise your hand and I'll back it out a little bit, okay? But let's get started. This is a list of things that really make up 90% of what I see in my office. If you come to see me for a knee, there's a 90% chance that what's wrong with you will be on this list. So what I want to do is tackle each of one of these one at a time. Before we do that, though, just so it'll make sense, I need to go over some simple and basic things. I've always found that if you really want to understand something, the best thing to do is take it apart and put it back together again. So we'll do that with the knee. And the list of parts that we need is pretty small: 4 bones, 2 tendons, 4 ligaments, and 2 types of cartilage. And with that little parts list, we can actually make a knee. So let's get started. The first thing is the femur bone. Okay, and the femur is the bone that starts in your hip. It goes down to your knee. So that's this upper bone. The second bone beneath it is the tibia. That's this one. That's the one that looks a little bit like a golf tee. And then there's another bone right next to it called the fibula. That's this skinny little bone here. Okay, so these 3 bones come together to make the joint, the hinge part of the knee joint. This is looking at it from the front. That's how it would look looking at it from the side. That system of bones is held together by ligaments. And ligaments are tough bands of connective tissue that attach from one bone and down to the other bone, almost like a bridge. And you can see a ligament here on the side. That's an example of a ligament. These 3 springs on this model equal 1 ligament. And what ligaments do is they allow for normal motion, but they resist abnormal motion. Okay? They kind of hold the joint together. The next thing we'll do when we make our list or put our knee together, these are just labels of what the ligaments are called. The ones on the outside that prevent this kind of motion from side to side, those are called the collateral ligaments. And then there are 2 in the middle that make sort of a cross or a crucifix, and they're called the cruciate ligaments, and that's how they got their names. The one in the front is the anterior cruciate, and the one behind it, kind of hard to see from the front, is the posterior cruciate. And if you're close enough, you can actually see those. This is the anterior cruciate here. If I turn the knee around to the back, that's the posterior cruciate ligament. And the collateral ligaments on the side are there to help keep this from happening, side-to-side motion. The cruciate ligaments prevent forward to backward instability. Okay, so the ligaments each have their own job to stabilize the knee. Next ingredient we need to add is the articular cartilage. And articular cartilage is a layer of material that's on the surface of the bone. And it coats the surface of the femur bone and the tibia bone underneath it. I always tell patients it's just like what you see on the end of a chicken bone, that white glistening material that your mom called gristle. We have that on the end of our bone also. And it's really amazing stuff. It is extremely slick and slippery. It has a coefficient of friction or a slipperiness 10 times better than an ice skate on ice. So it's an excellent low friction bearing surface, which helps make joints easy to move. The other thing that's neat about it and unique about it is it has no nerves in it. It has one of the few tissues in your body that doesn't have any nerve endings in it at all. And because of that, you can rub these surfaces together with a lot of force and not feel it. And if you think about moving a normal joint, when you move a normal joint, we don't feel, in fact, we're not even aware that things are rubbing in there because of that numb coating of cartilage on the surfaces of both of the bones that are rubbing against each other. So that's an important structure for our knee, this cartilage surface that coats the end of the bones. The next thing we need to add are the meniscus cartilages. And these are 2 horseshoe-shaped pieces of tissue. I'm going to open the back of this knee. If you look at the top of the tibia bone, there are 2 horseshoe-shaped pieces of cartilage. It's unfortunate that they're called cartilage, and we just described this surface coating as cartilage. They're both types of cartilage, but the meniscus cartilages, these horseshoe-shaped pieces of cartilage, are very different from the cartilage that coats the end of the bone. So we have 2 of those. a medial meniscus on the inner side of the knee and a lateral meniscus on the outer side of the knee. Okay, so medial meniscus here, lateral meniscus here. And if you see the model, you can see if you're close enough that there are a meniscus on each side. Okay. The next step, we got to put on the kneecap and what we call the extensor mechanism. And you'll notice that there's no kneecap on this model. This is the same model with the kneecap on it. Okay, and the kneecap sits in front of the knee like that. It doesn't fly around like that. It's actually attached by some important attachments. The attachment that attaches to the bottom of the kneecap and connects it to the tibia bone, the lower bone, is called the patellar tendon. And up above here, the patella, the kneecap, is attached to a little section of tendon that attaches to the quadriceps muscle. And the quadriceps muscle is the muscle on the front of your thigh. It's a big, powerful muscle. And when it works, it pulls on the tendon that attaches to the kneecap, which pulls the kneecap, which pulls the kneecap tendon, which moves the bottom bone. So it does that. Its purpose is to straighten the knee out. And this happens 1,000,000 times every day. And every time it happens, we use the quadriceps to pull on the kneecap to straighten the knee. So we call that chain of structures the quadriceps muscle, the quadriceps tendon, the patella, which is the kneecap, and the patellar tendon. That's called the extensor chain or the extensor mechanism, that group of structures all organized one right after another to help extend the knee. So now that's it. We've got all the stuff to build a knee. You're probably thinking there's some skin and stuff. Okay, there are some other things, but this is the important stuff in terms of what you'd need to understand what we're going to talk about today. And this is just a picture trying to show it all on one picture. Now we can start talking about what goes wrong in knees. And the first topic I want to start with is ligament injuries. So remember, we just were talking about the fact that the ligaments are these bands that help hold the joint together. And those ligaments, if you put enough force on them, can tear. And that can cause a problem. We'll talk about what the problems are and what the solutions are. When we visit with patients, we ask a bunch of questions. We try to figure out what it is by your answers to those questions, and we call that part of your evaluation the history. Okay? So the things we look for in the conversation with you, I want to ask you about a high-energy injury that you might have had. Realize that these ligaments that I'm showing you are as big around as your finger, so it takes a lot of force to tear them. This wouldn't be the kind of injury that happens, you just kind of wake up one day and your knee hurts and you don't really know where it came from. That's unlikely to be a ligament injury because it takes a lot of force to pop a ligament. And that's something you're going to remember if you have that kind of an injury. So when you're telling me about your knee problem, and if you tell me you had a big high-energy trauma injury, like you got hit by a middle linebacker, or you fell skiing, or you tripped off the stairs at your house, I'm thinking, okay, this could potentially be a ligament injury. Another really helpful piece of information is if you tell me you feel a pop. Now, a ligament is so strong that it will store a lot of energy before it fails. And when it fails, it can create a pop that you might feel. You might even hear it. And the person next to you might even hear it. So when people tell me a pop, that's a clue for me that their injury might be a ligament injury. The swelling that happens, that's a plus or minus. Sometimes you get swelling. A ligament isn't particularly vascular, meaning it doesn't have much of a blood supply. When it tears, it does weep a little blood into the joint, which will make the joint blow up after a couple of hours. Another thing is that after you sort of heal your injury, after you get better in a couple of weeks, your main complaint goes from pain, which is what you complain about in the first couple days after the injury, to wobbliness. Okay? If you knock out one of these ligaments, the knee becomes unstable, and then pain kind of goes away, but you'll notice that the knee gives out on you. And that giving way or wobbliness we call instability. And that's another clue that your injury might be a knee ligament injury. When we see you in the office, we finish talking to you, the next thing we usually do is we examine you. And there are some things I can do to your knee to check it that will help me understand whether this is a ligament injury or not. The ligaments in your knee, we talked about their purpose. This is sort of a drawing trying to do what I was doing with my model. The outer ligaments, the collateral ligaments, they keep the bottom bone from swinging back and forth. And the cruciate ligaments in the center keep the bottom bone from sliding forward or backwards. So our tests, the tests I would do on you to examine you, are sort of derived from these principles. The ligament test we use to check the inner ligament, the medial collateral ligament on this side, I just have you lie down, and I'm going to do this to your knee to see if the ligament's there or not. I put one hand above your knee, another hand below. I'm going to push towards your other leg with the upper hand and pull away. That's going to stretch this ligament just like this, okay? And if that ligament opens up a couple of millimeters, a tiny little bit, and then stops, nice and crisp stop, that ligament is okay, okay? If it hurts a lot when I do that, you may have sprained the ligament. And what I mean by a sprain, I mean that the ligament is there, it's not torn, but it's just stretched and sore, okay? So someone with a sprain of that ligament may feel pain when I do that, but the knee won't open up like a book. If you've torn it, then it'll open up like a book, okay? So I'm checking how far does it open and does it hurt you when I do that? And those are the clues I'm looking for to understand whether this ligament is part of your injury or not. So imagine if we're going to check the other ligament. On the other side, we just do the opposite motion. Have you lie down on your back. This time, my upper hand above your knee is pulling toward me. The lower hand is pushing towards your other leg, and that's going to stretch out this other ligament here on the other side. I look for the same thing. Does the knee open up more than it should? And is there pain when I do that? And those will help me understand whether or not you have this collateral ligament injury. To check the cruciate ligaments, that's these ligaments inside the knee, we're going to do something similar, remembering that those ligaments control forward and backward sliding of the tibia. I get you in this position and kind of sit on your foot so it doesn't move, and I'll pull the bottom bone forward. And when I pull the bottom bone forward, this ligament, which is the anterior cruciate ligament, goes from loose to tight, okay? And then I can also, in the same position, push the bottom bone backward. So now I'm pushing instead of pulling. And when I push the bottom bone backward, the posterior cruciate in the ligament in the back, it'll get tight if it's there and if it's working, and it'll stop the tibia bone from going backwards. So how much the tibia bone slides forward and backwards, that helps me understand whether or not your cruciate ligaments are working or not. So by rattling your knee around like that, I can get a pretty good idea about the collateral ligaments and the cruciate ligaments, the ligaments that hold your knee together. Sometimes we can figure it out just based on the story that you tell and how your knee behaves when we examine it. Sometimes we need extra information, and the extra information often is an MRI, okay? And this is an MRI picture of a knee. This is looking at the knee from the side, okay? And what an MRI does is it takes pictures in slices. So the slice that we're looking at is actually a slice right down the middle of the knee looked at from the side. So this is the upper bone, that femur bone up here, and this is the lower bone, the tibia bone, and going from the bottom bone up to the top bone, that dark band is the anterior cruciate ligament. I'm just using that as an example. And to make it a little clearer, I put a little yellow line around it in this slide. So there's the anterior cruciate ligament. This is where I've drawn the yellow lines to make it even stand out better. And this is an example of what it would look like if the anterior cruciate ligament is torn, okay? So that's an MRI showing a torn anterior cruciate ligament. And the MRI is a really helpful test. If we can't figure it out in the office, it'll help us find these ligament tears that maybe are harder to figure out when you're examining somebody. So this is a helpful tool also if we're unable to determine the diagnosis from our history, which means talking to you, and our examination, the physical exam. Next step is to talk about treatment. So let's say you have a ligament injury. What do we do to get it better? It depends, and it depends on which one you've torn. It turns out that the collateral ligaments, the ones on the sides, heal best without surgery, okay? They live in a very rich environment, a lot of nutrients. They're in around the muscles, where a lot of blood vessels attach to them all the way up and down their whole length. So they get a good supply of building blocks and healing tissue, and they actually heal pretty well without any surgery. So if you're unlucky enough to rupture your collateral ligament, the good news is it's likely going to heal without an operation. That's different from the cruciate ligaments, the ones in the middle. When they tear, they don't have much of a blood supply, so the two stumps don't tend to stick together anymore. They will not scar back together and heal naturally, okay? So if you have a collateral ligament, let's say that you've torn one of these outer ligaments, the ones I say that will heal, your knee will be very, very unstable, and it may even be unsafe until those things knit together. And that takes about 6 weeks to 3 months. And during that time, we'll often put you in a brace, okay? And the purpose of the brace is to allow normal motion, but to resist this side-to-side motion that puts tension on that ligament. So if you imagine you're the ligament, you're two stumps that are trying to stick together. If you're constantly pulling apart, it's going to make it harder for it to heal and take longer for it to heal. So the purpose of that brace is to keep those stumps next to each other, let them knit together good and strong, and then you can get rid of the brace after that's happened. What's kind of interesting in orthopedics, once upon a time, we treated these ligament injuries in a cast, okay? And in a cast, there's no motion, which you think, aha, that's good, because the two stumps are really going to be able to hunker down and sew together that way. And they all healed, okay? We took the cast off, and your little shriveled leg was very stable, okay? The problem is it was a little shriveled leg with muscle atrophy and stiffness in the joint from not moving it. And that changed when an investigator named Savio Wu in San Diego did an experiment where he created medial collateral ligament injuries in lab animals, and he took half of his lab animals and he put them in a little cast that held their legs still so that that would heal. And he took the other half of his group of lab animals and he put them in little braces that let the knee bend. And he found that after the right amount of time, about a month, both of those groups of lab animals healed the ligament injury, okay? But when he looked at the little ligament that had healed under the microscope, the ones that had been in the cast, the healing tissue, the fibers, were all just kind of randomly oriented. And the one that had motion, the fibers were oriented like this, long-wise, like the ligament fibers naturally are. And that made a difference when he took those ligaments and pulled them apart in a machine and measured how much force it takes to pop them. The ones that were randomly oriented tore a lot easier than the ones that had their fibers lined up the right way to resist that kind of load. So that was sort of the birth of the idea of sports medicine. And the idea of sports medicine is to allow motion and more aggressive rehabilitation after an injury instead of just putting people in a cast. So we learned from that study that these ligaments heal best if we avoid this kind of force, but we allow this kind of force. And a hinged brace like that lets that happen. It's a different story again for the cruciate ligament tears, and I'm going to talk mostly about these ACL tears. It's rare to tear your posterior cruciate ligament. It's pretty common to tear your anterior cruciate ligament. So I'm going to use the anterior cruciate ligament as an example when we talk about cruciate ligament tears. Anterior cruciate ligament tears are relatively common. They don't heal. We said that before because the blood supply isn't good enough for them to scar back together. And if you don't treat them, you're likely to have a knee that is going to be sloppy for the rest of your life. And knees that slip a lot wear out faster. So without treatment, you're likely to get arthritis later in your life. And a patient that I see a lot is a patient who is maybe 40, 50 years old. They had a high school knee sprain. They remember it was pretty bad. They had to sit out for a couple weeks. They finally got back, but ever since then, if they're doing something athletic, once in a while their knee will just give out on them. Maybe it's at the company barbecue, you know, a volleyball game or something. But ever since then, they've had a trick knee. That's a patient who tore their anterior cruciate ligament, never had it fixed, and now has an unstable knee. And by the time they're 40 or 50, they're here to see me because their knee's worn out and it's arthritic and needs a knee replacement. So we understand now that stabilizing the knee is important. It's important because it gives you a reliable knee that you can do sports, or if you're a laborer and need to be on a ladder, you can have a trustworthy knee. And it's also important because it lets you avoid arthritis and destructive changes that happen if you don't treat the ligament injury. So we're more aggressive about treating ligament injuries than we used to be now that we understand the consequences of leaving them untreated. You can use a brace for a cruciate ligament tear. We said we use braces to control wobbliness in the collaterals. There's a type of brace that helps control this tibia sloshing forward and backwards. The big difference is that this brace would have to be worn for life, okay? The collateral ligaments, they heal in about 6 weeks. So after 6 weeks, you take the brace off and you're ready to go. But in 6 weeks, that anterior cruciate ligament tear isn't going to be any more healed than it was when you started wearing the brace. So if you're going to use a brace as a solution for an anterior cruciate ligament rupture, you're likely going to need to use it for life. And not many people will use a brace for life. It's too inconvenient. So for that reason, we have another alternative, and that's surgery. And our thoughts about the surgery for anterior cruciate ligament tears those thoughts have evolved over time. We learned the hard way generations ago that you can't sew the two stumps of the torn ligament back together. We talked a minute ago that they just don't have enough blood supply to heal. So it's like the white part of a fingernail. If you sew that torn fingernail back together, it's just not sticky enough to heal, and those stitches pull out, and then you've got a torn ligament again. So we don't do end-to-end repairs, even though that seems like that would be a good solution. The ligament has to be replaced with a graft. And graft is a ligament substitute that we put in to take the place of the ligament. And there have been a couple ideas about what to use for a graft. Before the 1970s, it was pretty much all over the map what people used. Some surgeons used parts of your knee like the meniscus. They would take a healthy meniscus out and use it to rebuild, bridge across the knee. That was before we understood how important the meniscus is. We learned right there how important it was pretty soon. Other people took part of a gristle from your thigh. There was really no consensus about what to use for reconstructing ACL anterior cruciate ligaments. About that time, we had appear on the market an artificial ligament, a ligament made of Gore-Tex, same stuff that your sleeping bags and jackets are made out of. And it's a really strong material. And the little rope, it looked like a little rope about the diameter of your pinky finger. And that rope, if you put it in a machine and pulled on it, it actually outperformed the anterior cruciate ligament from a human. It was stronger than an anterior cruciate ligament. So we thought, boy, this would be great. You know, we'll use this in people's knees. It might even be an upgrade in terms of strength. And the bad news about that graft and all grafts that are artificial is that just like a paper clip, if you bend it back and forth enough times, it starts to break. And that happens to your natural ligament. But when it happens in your natural ligament, if a little fiber inside that natural ligament tears, it gets repaired right away. And that's the beauty of living tissue. Living tissues have a self-repair function. So little tears and injuries to those ligaments, little tiny microscopic ones, are constantly getting built and rebuilt all day long. So there's no accumulation of fiber wear as you bend and straighten your knee. The Gore-Tex graft, that's not true. The Gore-Tex fibers are rupturing with use, and as soon as they rupture, they're gone, and they never get rebuilt. So the rest of the fibers get more load as fibers drop out, so the thing fails eventually. And all of those Gore-Tex grafts failed, and to make things even sadder, as they failed, they generated little particles of Gore-Tex which were very inflammatory and irritating to the knee. So they caused knees to get hot and swollen, and it was very hard to surgically remove all those little particles because they're too small to see with your eye, so it was kind of a mess, this Gore-Tex graft idea. But it was a hot item for a short period of time. Then in the 1980s, we decided, okay, what we'll do is we were starting to get a fair number of cadavers for medical use, people donating body parts. So we figured, okay, we'll use cadaver tissue. We'll take a dead person's ligament and put it in you. And the thing that's interesting about cadaver tissue, human cadaver tissue, is if you install a ligament, a cadaver ligament, your body will actually grow blood vessels into it, and the cells of your body will populate it. So it doesn't have that problem that the Gore-Tex had. Once it's repopulated and living, it has that self-repair function. So what we really were doing is putting in a scaffolding that allowed your body to grow in and make its own ligament. And this was really exciting because then we had a ligament that we could implant that became self-repairing and should last as long as a regular natural anterior cruciate ligament. And the bad news was when the first patient got AIDS from a graft. And it turns out that unfortunately those grafts can transmit disease if the donor of the graft had a disease. And that led us to rethink using cadaver grafts. We still use them, but now the cadaver grafts are treated. And the treatments we have, we can soak it in a chemical called ethylene oxide, or we can irradiate it with radiation. And those methods of sterilization are very good at killing the germs inside the graft, so you don't give your patient a disease when you put a graft inside them. But those methods also weaken the tissue. When you sterilize the graft by irradiating it or chemically treating it, you weaken it and it tears easier. That fragility that you get from sterilizing it is temporary because remember, your body's going to grow in and repopulate it and make it you. And that process of converting it from the cadaver to you is about a 2-year process, we think. And after 2 years, that vulnerability or that fragileness that you get from sterilizing it will be gone because it's your own tissue. But during that first couple of years, it's a little weaker because it's been irradiated or cleaned with chemical. So we have to protect you a little more against rupture. The other option, and this is a popular one now, is to use autograft. Okay, that's using the patient's own tissues. And autograft options, we can use the hamstrings or we can use the kneecap tendon. And this is an example of both techniques. This is using the kneecap tendon. And when we take the kneecap tendon, remember that's the, we looked at that when we built our knee. That's this little tendon that connects the kneecap down to the bone beneath it. It's a wide ribbon-like tendon, and we can take a central stripe out of it and it will heal. Okay, so we don't weaken it enough that it will injure it. And we take that little stripe out and we leave a chunk of bone on the top and the bottom. So what we take out of the knee to use as a graft has a piece of bone on both ends and nice tough ligament material in the middle. Alternatively, we can use your hamstrings. And the hamstrings, as most of us know, most of us remember that those are muscles that go down the back of your thigh. And at the very last second, they turn from muscle into tendon, and tendon is sort of like a shoestring type connective tissue. And the tendons wrap around the front of the knee right about to here and attach to the bone. So in that operation, we cut here and we cut there. They're pretty small and skinny, so we take a couple of them and we weave them together to make a graft. And then if you're going to use hamstrings, that's sort of what your graft would look like. Okay? Whichever graft you choose, the next step is to drill a hole in the bone, a tunnel about the size of your pinky finger, and another dead-ended tunnel up there. You put the graft up in here, and we have screws and things that will attach the graft on both ends. So we fasten it to the upper bone, we fasten it to the bottom bone, and now we have a ligament that's in there to be your new bridge, your new connector. And right now, I would say about half of the people getting ACL reconstructions are getting cadaver grafts that have been treated. And the treatments of the sterilization process is getting better all the time so that there's less and less weakness from sterilization. About half the people are getting their own tissue put in using either patellar tendon or hamstring tendon. And we've done a lot of studies. There are a lot of people getting this operation, so we've done a lot of studies trying to figure out which is the best. And it's pretty much a tie. It looks like they both work really well. So either one is an option if you're looking at having your ACL reconstructed, and they both work well. It's a pretty good operation. 90% of people who have that operation have success in restoring stability in their knee. 75 to 80% go back to sports, and by that I mean they go back to sports at the same level that they were at when they got injured. That's pretty good. It's not great. It'd be great if that were 100%, but an ACL tear is a pretty big injury, and it's not often that you can come back 100%. The other nice thing about it is that it significantly decreases the arthritis later in life. And we're about ready to take the predicted out of here. We've followed our patients with ACL reconstructions long enough now, and you have to follow them for decades, maybe 30 years, to see if it makes a difference. And it really does. The data are pretty strong there, that if you get your ACL reconstructed, you decrease the chance of getting arthritis. Now, it's important to understand, and this point isn't made clearly enough oftentimes, that if you have your ACL reconstructed, you don't then have the same risk of getting arthritis that you would have had if you'd never been hurt. Okay? It's not that way. If you've had your ACL torn, you get it reconstructed, you're still at a many times higher risk of getting arthritis than if you had a normal uninjured knee. What I'm saying here is that if you have an ACL tear, you get it fixed, you're at a many times less chance of getting arthritis than if you had an ACL tear and you left it alone and left it unstable. Okay? Let's go on to the next topic. Next topic is what happens when you hurt your meniscus cartilages. Remember, those are the two horseshoe-shaped cartilages. We have one on the inside, one on the outside. If you look down, if I could take the top bone off and you could look down at it from the top, the meniscus looks kind of like this, and that's what a meniscus tear looks like. And the tear will often, the torn flap will often move in and out of the knee, so there's sort of a catching sensation that people complain of. It's almost like having a hangnail on your thumb. It's irritating and it causes pain there because of the motion and instability of that little flipping flap that you see right here in this meniscus. This is a normal untorn meniscus. Again, when we meet people in the office, we ask them questions. The main clue for me that somebody has a meniscus tear is they talk about pain on the side of their knee, either inner side or outer side. That's a clue that the meniscus is what's injured. If they tell me that they have trauma, that's an important clue. The interesting thing about meniscus tissue is as you get older, it gets more brittle. So you get over 50, and you can tear your meniscus with something really innocent, like just lifting a heavy trash can and moving to the side like that. That would be rare in somebody who's under 20. Most people have to have more of an injury to tear their meniscus because the meniscus is much tougher when you're younger. But as you get older, it can be pretty easy to tear. The mechanical symptoms, by that I mean you might tell me that you're getting catching or locking, and that's a clue that that little piece is moving around inside your knee. And then the last thing is swelling. And swelling in knees happens under a lot of conditions, but it can happen because that little flipping piece is irritating the joint. It's not a very specific sign, but it certainly can be a sign of a meniscus tear. When I examine you, I look for these things. Are you tender at the place on the side here where the meniscus is? Either on this side if it's the medial meniscus, or on that side if it's the lateral meniscus. So joint line tenderness is a big sign for me. The other thing I look for is pain at this joint line when I bend your heel up towards your butt. And the reason that happens is there's a little, this top bone, the femur, is shaped like a cam, which means that it has extra material in the back. And just like a nutcracker, when you bend it down, that comes down to bear on the meniscus. If you have a torn meniscus, hiking your heel up towards your bottom squishes down on the meniscus, and that can recreate pain. And then the last test is this thing called McMurray's test. And when I do McMurray's test, I'm basically grinding the meniscus between the two bones. So I'm going to take your lower leg and upper leg and just do this. And if you have a meniscus tear, that will usually hurt. Okay? And you might smack me. But, if you have a meniscus tear, the good news is there's a 50-50 chance that you will heal it. Okay? The meniscus has a pretty good blood supply, and 50% of people who come in with a meniscus tear won't have that pain or any problems about 6 weeks later. So we don't have to operate on all of these. We only have to operate on the ones that don't get better after about 6 weeks. Exceptions to that rule, if your little flipping piece gets stuck in the knee and the knee is locked, then we operate, because it's not going to heal if it's way out there and not back where it belongs. Or if your knee has a very, very tense effusion, meaning that it's swollen up like a basketball and the skin is as hard as a balloon that's going to pop. Those knees we operate on because the knee is just very, very inflamed. Those are rare. Most people with meniscus tears don't get locking and they don't get that tense swelling. But you got a 50-50 that you're going to still have trouble in 6 weeks. And if you still have trouble in 6 weeks, the best operation for you is an arthroscopy. And the arthroscopy is an operation where I take a tool about the size of a pen, and it's actually, arthroscopy tools are getting smaller and smaller, so a pen's actually a little big now. But you put this inside your knee, and with the tool inside there, we can trim out, the torn flap. That's just the torn piece, and that's after we trim it out. Or if the tear's way back in the back of the meniscus where the blood supply is good, we can actually put in some stitches arthroscopically and sew it together so it will heal. Okay? And which operation we do depends on where the tear is in the meniscus. Unfortunately, they tear a lot more here because the meniscus is thinner there. So we do a lot more of these trim out operations than we do the stitching back together operations. But both are done for meniscus tears. And that's a good operation. 45 minutes, that's on the long side. It's usually even less than a half hour. Very high success rate in terms of patient satisfaction, 80 to 90%. Very high 80 to 90% chance of getting you back to sports and back to sports at the same level where you were before you got hurt. And good results for decreasing the development of arthritis. That piece that's flipping around in there is apt to scratch up the surface of the cartilage coating. We were talking about that cartilage coating. If that gets scratches in it, then just like a bearing in a machine, it's going to wear out faster. So we want to keep that surface from getting scratches in it. And we do that by trimming out the torn piece of the meniscus that's catching in your knee. So speaking of arthritis, let's go to arthritis. Arthritis is a problem or a disease that affects that layer of cartilage we just talked about that's on the surface of the bone. Okay? This is a gross picture, but this is what it looks like when you open up the knee of somebody who has bad arthritis. The yellowy stuff is the cartilage, and there are big areas here. This is looking at the end of that bone, just like that. Big areas on that femur bone where there's no cartilage, and that's exposed bone. And we talked a second ago about the fact that cartilage is slick and numb. Now, bone's just the opposite. Bone is very rough and abrasive, and it's very sensitive. If you've ever worked on your teeth at the dentist office, you know how sensitive bone is. So in people who have worn the cartilage off, they've gone from having a slick, numb surface rubbing against the other side to a rough, abrasive surface. The good news is we don't have to open you up like that in the office to see if you have this problem or not. We have a less barbaric way to check it out. The best tool for figuring this out is actually an x-ray, and this is an x-ray of somebody with normal knees. And this person's standing for this x-ray, and even though they're standing with all of their body weight pressing these bones together, there's still a big space between the two. And the space is there because that coating material is invisible on the x-ray, just like skin and muscle are invisible. So there's something in there, but it's just something we can't see on the x-ray. It's the layer of cartilage on the femur bone, above bone, plus the layer of cartilage on the lower bone. So the thickness, the distance between here equals the sum of the thickness of the upper and lower layers of cartilage. Okay? Compare that x-ray to this x-ray, and this person has no cartilage there. Okay? This is like the knee that was open a couple slides ago. There's just raw bone, and as soon as you get raw bone on the upper bone, it's so abrasive that after a while it'll tear up the meniscus and tear through the cartilage on the lower bone until you have bone rubbing on bone. So this is an x-ray that shows bone-on-bone arthritis. And without any MRI or fancy test, I can tell you with 100% accuracy that you have no cartilage in that knee. Okay, a simple, inexpensive x-ray tells the story. You have good cartilage over here, and your other knee looks pretty good. You're a little narrow here, so you have some early arthritis there, but not down to bone on bone, and a pretty good space over here. As far as the questions we ask, the biggest clue that you have arthritis as your knee problem is age, or more accurately, a high mileage knee. You can be a young person, but run a lot of marathons and have a very physical job and be a little overweight. That knee is getting a lot more mileage on it than somebody 10 years older than you that is a swimmer and fit and thin. So it's really like a car. It's not just the year of the model, but also how hard it's been driven. And the high mileage knees are the ones that are at risk for getting arthritis. Past trauma, if you have an injury, we just said that if you have an ACL tear that never got fixed, that sloppiness in your knee will grind off those cartilage surfaces faster. So a history of trauma in the past. There are some diseases that attack cartilage. Rheumatoid arthritis is a disease where your own immune system, the system in your body that's supposed to kill germs, gets mixed up and it attacks your cartilage surfaces. So it's an autoimmune disease, so it destroys cartilage. It'll melt it all off of there and get you down to bone on bone. And previous surgery, anything that might leave a mark or a scratch, an injury or an operation, just like in a bearing in a machine, you have an imperfection and you cycle it over many cycles, it will accelerate the wear rate and make it wear out. We see some things when we examine people, and one of the biggest clues for me is what we call angular deformities. And this is a type of angular deformity which I think my grandma would call that bow-leggedness. And it just means that when you bring your legs together, you touch at the feet before you touch at the knees. And you should touch about the same at both places, okay? If you're touching at the feet way before your knees ever get to touch, that means that you've probably worn out the inner side of your knee, okay? There's an opposite thing, knock-kneedness, where you wear out the outer side of your knee, and that puts an angle. Whenever you have asymmetric wear, it makes the knees angled, either in or out. And that's something you can see without anything other than just looking at somebody. As far as treatment goes, we have a long list of treatments that are pretty effective that are non-surgical. If you have bone-on-bone arthritis, there is a good chance that you can get good relief without having to have any kind of an operation. And the list of things starts with anti-inflammatory medicines, and this is Advil, Motrin. There are 32 of these, some prescription, some over-the-counter, Aleve. What those medicines do, they do not apply new cartilage to the surface of the bone. It'd be great if they did, but they don't. And what they do is they decrease inflammation and swelling. It turns out that when those bones rub against each other, that's a very high friction bearing. And the knee's not used to that. The knee's used to a slick, slippery bearing. If you have something creates friction inside of there, the knee responds to that by pumping in extra lubrication fluid. And that makes the knee puffy and swollen, and it makes there more pressure in there. And that pressure is a part of what hurts your knee. So these anti-inflammatory medicines just decrease or deflate that swelling, so it takes the pressure off your knee. And that can make a big difference in how you feel. Supplements, these are things like glucosamine and chondroitin sulfate and SAMe. There's a long, long list of these. If you go to a GNC store and ask the person to show you their rack of things for arthritis, there's a lot of this stuff. Most of it is chemical, and it's chemical that you see in cartilage. Okay, glucosamine and chondroitin sulfate. These are the chemicals that make up that layer we're talking about. And the concept is, okay, if you don't have this stuff, I'm going to eat the ingredients so I can grow it back. And unfortunately, that doesn't work well. If it did, I would run over to the barber shop and eat all the hair off the floor so I could fill in my little spaces here. There isn't a solid connection between what you eat and what appears on your body parts. Despite having said that, I have a lot of patients, patients in my practice who take this stuff and feel good. So I think one thing to remember about this is it's not been shown ever to increase the space back to normal. So any company that claims that their stuff is growing cartilage back, I'm going to dispute that claim. But a lot of people feel better. Way better than I would expect if it were just a placebo effect. And the placebo effect is just the sort of the sugar pill effect of believing it's going to work. So I'm convinced that it was working in maybe some novel anti-inflammatory way or by some method that we don't understand. And that's something that's true of a lot of medicines, including aspirin. We observed the effect and used it for a long time before we figured out the mechanism of how it worked. So I never discourage people from using these things, but I would tell you that it doesn't grow back cartilage, even if the manufacturer claims that it does. Braces can help. There's a type of brace. Let's say you're the person that has the x-ray we showed where they're down to bone on just one side. There's a brace called an unloader brace, and what the unloader brace does is it cranks your knee over this way, okay, so that you're putting more weight on the part of your knee that still has cartilage. It doesn't take all the weight off your sore side, but it redistributes more of it off the sore side. It's a pretty cumbersome brace, meaning it's kind of bulky, kind of Forrest Gump type of brace, not super comfortable, and because it doesn't give you 100% relief of your symptoms, some patients don't like it. It's almost like if you had a pebble in your shoe and I just taught you to walk on the other side of your foot, it feels better, but it's not perfect. Okay? And unloader braces can be good for some patients don't get that much out of them. A cortisone shot is a way to put anti-inflammatory medicine right in the knee. One of the things that we learned about anti-inflammatory medicines is that they can have damaging effects on your body. They're a great medicine to use if you sprain your ankle. Sprain your ankle, you're sore, take the high-dose Advil for 2 weeks. 2 weeks later, your ankle's healed, and you're good to go. If you have bone-on-bone arthritis in your knee, in 2 weeks, you're going to have bone-on-bone arthritis in your knee. So you would need to use, if you're going to use Advil as a method of curing your knee problem, you need to be on, and you have bone-on-bone, you're going to need to be on high doses for months and months and months. And that can, in some people, cause stomach lining damage, and it can cause kidney damage. So we still use it. In some people, it's very effective. It works because it decreases the inflammation. But you have to be careful, and you have to monitor kidney function and stomach, all these other things that it can damage. The nice thing about cortisone is it does the same thing, but because we're putting it into an injection and putting it in your knee with a needle, it doesn't get in your stomach, it doesn't get in your kidneys, it just affects the knee. So it's a way of directing a surgical strike of that medicine right into the joint and not into your whole body the way that pills that you take do. So that's an advantage to cortisone injections. There's a type of injection called viscosupplementation injections, and these are a thick jelly-like lubricant, like a thick oil. Typically, it's a shot a week for 3 weeks, so it's a little more inconvenient than a cortisone shot. And we think that how it works is it's an oily substance, and it gets in there and lubricates the surfaces of the bone so that they don't rub with as much friction. And we were just talking about how friction is the stimulus for the overproduction of fluid. So if we can decrease friction, we can decrease the overproduction of fluid, which takes the pressure off the knee. And we think that that may be how these shots work. So that's on the list of possible things to use other than surgery. Weight loss, that's probably the least popular one when I suggest it to patients. But it works because it takes pressure off the joint. If you can unload that joint, just a mechanical principle, it doesn't hurt as much. Same principle applies to cane, crutches, walker, anything you can do to make your body weight go through that apparatus into the floor and not through your knees will make you feel better. Last but not least is physical therapy. And physical therapy helps because it can increase your range of motion and help you put weight on other parts of the surface that aren't as badly affected. There are probably half a dozen other things that you might say worked for you that aren't on my list. And this is not meant to be a comprehensive list. This is just the thing that we talk about most often. So the take-home point is the life isn't over if it's bone on bone. There are some non-surgical things that work well for a lot of people. If they're not working, then we have to talk about surgery. And we had some pretty bad operations for this problem in the old days, meaning pre-1970. And one option that we had was what's called a knee fusion. And in a knee fusion, we physically bolted the upper bone to the lower bone. And the raw surfaces would actually grow together, just like in a fracture, a broken bone. If you have two raw surfaces of bone and you hold them next to each other in a cast or with a device like that, they'll actually grow together. So once this is done, and this is an example of a successful fusion, the hip all the way down to your ankle is one bone, okay? So we were successful in taking away the grinding sensation of bone against bone, but it's at a big cost, and that's the cost of motion, okay? So your leg is frozen like that. That's one option. The other option we had pre-1970 was called an osteotomy. And this was really only an option if you had the type of arthritis that affected one side, like the x-ray we looked at. If you have normal cartilage over on this side, you can have this osteotomy operation, which is sort of like a surgical version of the brace. And what we do is we actually cut out a section of the bone and shut that gap, which swings the shaft of the lower bone over and shifts more weight onto the good cartilage that you have. Okay? And like the brace, it is partially successful. You still have some weight bearing, but the load has been shifted some over here. It's a big operation, long recovery period, and when you're all done, you get partial relief of your symptoms. But that's all we had. We had fusions and we had that, and we had crutches. I guess it's a testimony to how bad knee arthritis pain must be. People were lining up to get these things done to them, and it was all perceived by almost everybody as an improvement compared to arthritis pain. Fortunately, we had a big sort of improvement in our techniques for treating arthritis when we discovered knee replacement technology. And knee replacements come in sort of two flavors right now, a total knee replacement and what's called a unicompartmental or a partial knee replacement. And the total knee replacement is probably the most misunderstood operation in my whole practice. And it makes sense. If you told me that you were going to replace my knee, I'm going to imagine that you're going to chop here and chop there and put in a new knee. That's sort of what the name says, replacement. That isn't what we do. In a knee replacement, we do open the knee up and we do make some bony cuts, but they're just sliver-like cuts to shape the bone. We shape the bone and make it the same shape as the backside of this, drill 2 holes for those 2 lugs, and we bond this piece on there like a dentist puts a cap on a tooth. Okay? The bottom bone also gets a little slit in it for that keel, and we bond that piece on there, and we put it all back together, and you walk around on this. And these surfaces are numb, obviously, because they're made of metal and polyethylene plastic, and they're slick and slippery because they're polished, and they're actually lubricated by the saliva-like fluid that your knee makes, and it used to make it for its own bearing, and it still makes it for this. So you get a lubricated surface. It's a good solution. A better way to call it would probably be a knee surface replacement. That would more accurately describe what we do to a knee. But that's why it works, and it's a good operation. This is just a picture of that first knee I showed you after I put the pieces on it, and there's a piece that covers off the end of the femur bone, that's this piece, a lower piece that covers the top of the tibia. There's actually a kneecap piece, because the kneecap, when you bend your knee, it scrubs against here, so we put a protector on it too so you don't feel it when it rubs. And that's what a total knee is. All of the bearing surfaces in your knee are resurfaced with stuff that's slick and slippery and numb. A partial knee replacement can make sense if you have the kind of arthritis we saw in that x-ray where only part of your knee is down to bone. Okay? And a partial knee replacement, just like the name implies, is kind of a half of a total knee replacement. We just put a little piece on one side of the femur bone and a piece on the one side of the tibia bone and bond them on there. So the x-ray looks kind of like this. Okay? That's before and that's after. Same principle though, numb, slippery bearing surface replacing an old, rough, abrasive, sensitive bearing surface. And both of those operations are good operations. If you look at the unicompartmental, the partial knee replacement, one of the pros to that operation is I can do it through a much smaller incision, so your recovery time is much, much quicker. The cons are that there's a chance that if your knee is bad enough to be bone on bone in that one spot, you're going to have some issues in other spots in your knee, and those aren't addressed in a partial knee replacement. So you may still have pain from those areas, and also they don't last as long. Those other parts of your knee may wear out, and then you have to have your partial knee replacement converted to a total knee replacement. So if you're over 60, the statistics are excellent that a total knee replacement will last your lifetime. Okay? So it's hard to come up with a good reason to do a partial knee replacement because this is likely to go the distance and not have to be converted to a total knee replacement. But every patient has their own sort of factors about their particular case. In some cases, a partial knee replacement makes good sense. In some cases, a total knee replacement makes good sense. The principle's the same. It's just how much of the area that you're resurfacing that makes them different. The future in this is really interesting, and that's going to be cartilage regrowth technology. And there are cells in your body called stem cells, and these are cells that have the ability to make anything you can imagine. This one cell can grow up to be a heart cell, it can grow up to be a skin cell, it can grow up to be a cartilage maker, a cartilage cell which we call a chondrocyte. And what's exciting is that there are scientists who have figured out what chemicals to sprinkle on stem cells to make them become chondrocytes. That's already happened. And one of the centers that does a good job at this is right here in Colorado at CU Boulder. A lab up there is able to take stem cells and grow a layer of cartilage on the surface of a petri dish. Unfortunately, the cartilage is more like Jell-O. You can push your finger right through it, so it's still not ready for prime time, but it's on the way. And they're having some issues in turning in some labs they're having trouble turning the cells off. You don't want to turn these guys on and not be able to turn them off. So it's a ways from being in my hands as an orthopedic surgeon and something I can offer you, but there's a lot of promise there. It's going to be tricky once we get the stem cells to do what we want them to. It would be great if I could just inject them in your knee, but it would be bad to let them just go in your knee and make a blob of cartilage in the center of your knee. We're going to have to teach them to look at the knee and see the bald spot and go there only. And in the place where it's sort of ramping up to normal cartilage, there's going to have to ramp itself into that and feather into that. It's going to be very complicated. And it may be that the first iteration of this is that I send them your stem cells to the lab, and 3 months later they send me a film of this stuff that I'm going to apply to your joint. And then you think, well, how are you going to bend it around those surfaces, and is it going to stick? And maybe we use a computer and an MRI of your knee so that they grow it on a little, it's almost like those heads that you put a wig on. They're going to grow it on a little model of your knee so that it's a shape, it's like a swimming cap. I'll pull it off and put it on your knee. That's all science fiction right now. But those are ideas that may someday be something I can offer people, and that will be a much better way to treat down-to-bone arthritis than these clunkers, which do great, and they're much better than fusions and osteotomies, but they're not biological resurfacing. And I'm convinced that in our lifetime we'll have biological resurfacing with stem cell technology. We just don't have it yet. And once we have it, these will be great for archaeologists, because 2 million years from now, when they find one of these, they'll know that that layer of dirt was the layer from 1970 to 2020 when we put these crazy things inside of people. We've got a couple minutes left. I want to go through the last topic, which is problems of the kneecap joint. And every orthopedist hates talking about this, because this is like the low back pain of the knee. We do a real poor job at getting people better with this. Super common, very achy, breaky, nuisance pain, and we don't have great solutions for it. People who have this problem, it's more common in women. It's usually pain in the front of the knee that's worse when you're going downstairs. There's a bunch of you guys have it, it sounds like. It's worse with squatting down like a baseball catcher. And worse if you sit for a long time. They used to call it the theater sign, but in modern times they probably call it the long plane ride sign or something like that. Or if you ever go to Coors Field, the seats are so tight. Sitting with your knee really bent creates a pain in the front of your knee. Those are clues to me that you might have this patellofemoral problem, okay? And that's sensitivity in the space where my finger is underneath the kneecap, but on top of this bone, in this little joint here, okay? And it can be arthritis, or it can just be irritation in there. When I check you for it, I'm going to have you lie flat on your back and just kind of move your kneecap from side to side. And if that's very irritable for you, that's a sign that you have this. The other thing I'll do, and it's not easy to demonstrate in this slide, is I'll have you sit with your leg hanging over the edge. I'll put my hand on your kneecap and have you bend and straighten it. And if it's making a bunch of Rice Krispies crunchy, crackly stuff, that is a sign that you might have a problem in that bearing underneath your kneecap. Okay? A real important tool for figuring this out is X-ray. And this is the way we shoot the X-ray. We put the film down here on your shins, and we shoot the X-ray beam over your shoulder. So what we're looking at is a picture like that. Okay? And it comes out like that. That's not a mammogram. That's actually a pair of knees. And this is the kneecap, and that's the femur bone beneath it. And the space in there is full of what? Cartilage. Yep, same bearing surface that's on all these bones. And this helps me understand two things. It helps me understand how much space you have, and also how centered your kneecaps are. And one of the things that can happen with kneecaps, because they're so free, is muscle imbalances can lead the kneecap to track off center. And that can cause this patellofemoral pain. So we look at how thick the cartilage is and how centered the kneecap is. Here are just some examples. Here's one where there's obviously no cartilage left. That's bone-on-bone arthritis of the kneecap joint. Okay? This is somebody who's tracking abnormally. This one's tracking pretty well. This one's off. See how off that kneecap is? And once it's off, it starts to put a lot of force on this contact patch, and then you can start wearing off the cartilage. This one is off and down to bone-on-bone. Okay? And this is the sort of greatest hits kneecap pictures. This is somebody whose kneecap is so far gone that they've eroded the bone itself down to a little potato chip thin piece, and that's sort of end stage kneecap joint bone-on-bone arthritis. So those are X-ray findings that help me figure out that your problem's in the kneecap joint, not in the other part of the joint. As far as treatment goes, physical therapy can help. We try to strengthen or rebalance the muscles around the knee to help straighten out your tracking problem if you have a tracking problem. Braces can help. The brace you'll see has a kneecap hole. That hole is trying to control the kneecap and keep it in the center. There are some surgical solutions. They're not particularly successful. If you have bone-on-bone, knee replacement technology does help. We saw that plastic piece that goes on the patella. But for pain without bone-on-bone contact or tracking problems, we don't have great surgeries. The one that's probably used the most is what's called a lateral release. So this is looking up at your knee, and this is a kneecap that's off-center. This ligament is too tight. We divide that ligament, which helps the kneecap go back over to the center. You can't tell from this drawing, but that ligament isn't a rope, it's a sheet. And when we divide it, we put a slit in the sheet, so it's just like a buttonhole like this, so it makes it more flexible. Okay? So it increases the flexibility on this side, which helps the kneecap go back over toward the center. Probably about 70% patient satisfaction scores, meaning about 70% of patients are happy enough that they would do it again. 20% know better, and 10% we make them worse, by going in and monkeying with this. So surgical results aren't as good for problems in the kneecap joint unless it's bone-on-bone arthritis. Kneecap or knee replacement results are pretty good. That's it. That's all I got. I'll stick around forever doing questions if you guys have questions. But I appreciate your attention. You guys have been really nice and let me get that talk done without a lot of harassment. So I appreciate that. Thank you. Yeah, you bet.